اذا بدك نعمل اجتماع انا عبير بعد المحاضره.
لا إليك.
إلي؟ ثانك يو. هيني وراكي.
تعالي.
فيش جنبك حدا؟
لا. هي في بالونه كمان. مروح بالونه يلا.
أنا باللون. أنا بدي هاي.
Fetal growth restriction will be presented by Professor Ranjit Kapurika from UK. Please.
You have to press the button.
Yeah, can you hear me now? Yeah, perfect, thank you. So I'll end the day with a common topic, which is fetal growth restriction. I think it is something that is very common. People know about growth restriction, so I will try and keep it very brief and easy and simple. We'll discuss three things, and I think it will be nice if we can finish the talk with some very clear take-home points. So the question number one is, does fetal growth restriction happen in the first trimester? Yes or no? And if yes, then in which conditions? Number two is a brief management of fetal growth restriction in the second trimester. And then the easiest one, or probably the more difficult one, which is the third trimester. And of course, you're all aware that there are guidelines everywhere which specify that we have to date the pregnancy by fetal ground rump length. And why is that important? And again, even though we are all aware, but I think it is important to spend 2 minutes recognizing the importance of accurate dating, because dating is essential for diagnosis of fetal growth restriction, but also a lot of the things that we have spoken about throughout the day, whether it is screening for aneuploidies or whether it is diagnosis of fetal abnormalities. And this is one of the graphs that I showed in the lecture on stillbirths in the morning. And please have a look at this graph and see the incidence or the chance of having a stillbirth depending on the week of pregnancy at term. So you can see that the risk of stillbirth exponentially increases the further you go towards, the closer you go towards 42 weeks, which means that your risk is almost double in the 41st week of pregnancy, that is in the 48th week of pregnancy. Which means that if I have dated the pregnancy wrongly by 1 week, it will have a significant impact, because at the end of the pregnancy, it does matter whether you induce or deliver at 40 weeks versus 41 weeks, because the risk of adverse outcome is almost double. So this slide underestimates and underlines the importance of accurate dating in the first trimester, because even a small error can magnify the implications towards the end of pregnancy. So yes, it will happen at the end of the pregnancy, but it is something that you can correct at 12 weeks. Do not date by the last menstrual period. Again, there is a lot of literature around it. I won't spend any time on this slide. There are variations in cycle length, there are variations in date of ovulation. When you date by periods, it assumes that every woman has a 28-day cycle and they have an ovulation at the 14th day, which we all know is not true. There is a variation in cycle length, and even in women who have a 28-day cycle, ovulation can vary from the 12th to the 17th day. So dating by periods is unreliable. A lot of times when I see the reports from people who have had scans in many places, even though they have had an IVF pregnancy, people dated by the crown rump length. Please do not do that. When you have an IVF pregnancy, date it by the date of the embryo transfer, if it is a blastocyst transfer, which is day 5, or an embryo transfer, which is a day 3 transfer. So dating in a natural cycle is crown rump length. Dating in an IVF cycle is based on the date of the embryo transfer, and whether it is a day 5 transfer or a day 3 transfer. Always pay attention, because of that one graph that I showed you about the adverse outcome, as to how to measure the crown rump length. Even if you take 5, 6, 7, 8 minutes to try and to achieve a perfect crown rump length, make sure that the crown rump length is perfect, because that change and that inaccuracy in the crown rump length, whether the baby is curled up or whether the baby is extended, will have a difference of 4 days to 7 days. And there are studies that have actually looked at that. So you can see this reference that is there at the top, that if you have an error in the measurement of fetal crown rump length, by how much does it change your detection rate? And you can see small errors in the measurement of the crown rump length will affect your detection rate of trisomy 21. If you see the graph on the left, you can see that even if you have a 4 millimeter difference in the measurement of the fetal crown rump length, your detection rate may swing by 10%. So how you measure the crown rump length makes a difference to your false positive rate and also the detection rate. And it is not just screening for aneuploidies or trisomy 21, it is also the screening for fetal growth restriction. Here you can see this graph looks complicated, but both the graphs are the same. One on the left is for fetal growth restriction and one on the right is for large gestational age. Focus on the graph on the left. And the graph on the left shows you that if in real life the baby was on the 10th centile, which is the horizontal line, so the vertical axis is the y-axis, which shows you the estimated fetal weight percentile, and the horizontal axis is the gestational age. If I have undermeasured the baby by 4, not a lot, by 4 millimeters at 12 weeks, at 20 weeks, the baby on the 10th centile will be on the 30th centile. So it will change my estimated fetal weight centile by 20% with a 4 millimeter margin of error at 12 weeks. So accurate measurement of fetal crown rump length is absolutely essential in not just screening for aneuploidies but also screening for fetal growth restriction. And if you ask me the question as to does fetal growth restriction, because of which conditions cause fetal growth restriction in the first trimester, is it severe placental insufficiency? So if you had severely impaired placenta at 12 weeks, can it cause fetal growth restriction? No, it can't. There are only 2 conditions that can cause fetal growth restriction in the first trimester. One of them is digynic triploidy and second one is trisomy 18. If you look at all of the fetal trisomies, trisomy 21, trisomy 18, trisomy 13, the only trisomy that has early onset fetal growth restriction where there is a more than 7-day gap between the LMP dates and the ultrasound dates is trisomy 18, not trisomy 13, not trisomy 21. So when you have a big difference between your observed and expected dates, double check the biochemistry, double check for markers of trisomy 18. But number 2 is digynic triploidy. As you all know, triploidy can be diandric, where you have 2 sperms fertilizing 1 egg, which is diandric triploidy, where you have a large placenta and a partial molar pregnancy, or a digynic triploidy, where 2 eggs are fertilized by 1 sperm. And in that digynic triploidy, you can of course confirm it with genetic testing, but it is ultrasound diagnosis. There will be asymmetric fetal growth restriction. There will be a gap of more than 10 days between the LMP dates and the ultrasound dates. The head is as big as the body, the placenta is paper thin, and your biochemistry is extremely abnormal. So the 2 conditions that cause fetal growth restriction in the first trimester, trisomy 18 and digynic triploidy. So this is just a summary to say that when you have a gap of more than 7 days between your expected dates based on your periods and your ultrasound dates, if there is a big difference, double check the anatomy to exclude features of aneuploidy such as trisomy 18. Check the maternal biochemistry to make sure that you don't have any abnormal patterns. And again, when I say check biochemistry, it is very easy. In the median HCG in trisomy 18 is 0.1 mol. The median Pape in trisomy 18 is 0.2 moles. The median Pape in digynic triploidy is 0.05 moles. And the HCG, the median HCG in digynic triploidy is 0.03 moles. So the biochemistry is extremely abnormal. So you have a big gap in the LMP and the ultrasound dates. Check the biochemistry and you will be able to understand what is the underlying cause and then do appropriate investigations. And of course, it is important, as we said during the panel discussion, during various things, about making sure that the aim is to predict fetal health. The aim is not screening for Downs. The aim is not screening for hypoplastic left heart. The aim is to predict fetal health. And if the aim is to predict fetal health, examine the placenta. Do a ultra-aortic Doppler, examine for features of impaired proliferation, and if you have placental insufficiency reflected in abnormal ultra-aortic Dopplers in the first trimester and a low Pape, that pregnancy can either develop preeclampsia or fetal growth restriction because they are 2 phenotypes of the same pathology. So you have the same impaired trophoblastic proliferation, and depending on the maternal and fetal genotype, you can either develop preeclampsia only or fetal growth restriction only, or if it is very severe, you will have both. You will have early onset preeclampsia and fetal growth restriction both. So screen for it at 12 weeks because you can give them aspirin. So summary so far, from the first trimester, do not date by LMP, date by CRL in a natural cycle, date by IVF, and the date of embryo transfer in an assisted conception cycle. If you have a big discrepancy between the LMP dates and the ultrasound CRL, if you have more than 7 days, check the anatomy for features of trisomy 18 and triploidy, check the biochemistry, perform risk assessment for aneuploidies, but also check the uterine artery DI. And then the only research question that I have for you to think that whether we should consider dating by the BPD rather than the CRL if dating in the first trimester is important, because there is a lot of evidence to suggest that the time taken to measure the BPD at 12 weeks is maybe 1 minute, whereas the time taken to take a good CRL is 5 to 7 minutes, and the accuracy of dating is as good as with BPD as it is with CRL. And I will leave it there for anyone to have any questions later on. Fast forward to 20 weeks, when you have a small baby, these are the only 4 likely scenarios. You cannot have, so when you write reports and when you read things on the reports, and when you look at the textbooks as well, some of them mention that you can have a constitutional smallness. No baby can be constitutionally small at 20 weeks. You cannot have a constitutionally small, even in a 4 feet tall Asian woman or 4 feet tall short woman, you cannot have constitutional smallness in the second trimester at 20 weeks. Constitutional smallness is a third trimester diagnosis. So if you have a small baby at 20 weeks, it is always because of one of these 4 things, either a genetic etiology or a structural etiology or a placental etiology or infections. What baby you have at 20 weeks is biological development, and what the parents have inherited to the baby. So if there is a short mother who inherits a short skeleton with a short femur, that will show after 24 weeks, not at 20 weeks. So when you find a short femur as constitutional smallness, that is at 26, 28, 30 weeks, not at 20 weeks. So at 20 weeks, it is one of those 4 things. And again, when you assess growth restriction, I possibly cannot talk about all 4 causes in this short presentation at the end of the day. And there is a different discussion to have for investigation of genetic smallness, investigation of structural smallness, investigation of infectious smallness, because the more you do, the more easy it gets. You could almost tell by looking at the scan whether this is CMV and this is toxoplasma or it is not, or it is parvovirus. So infectious smallness looks different and structural smallness looks different. But you also have to focus on what is the reason for why the baby is small. Because when you look at the Hadlock formula, when you look at the Hadlock algorithm, it takes into account the BPD, the head circumference, the abdominal circumference, and the femur length. All of the 4 things go into the algorithm to create the estimated fetal weight. So you have to ask yourself, which is the component of that Hadlock formula that is causing me small for gestational age at 20 weeks? Is it because the head C is on the 50th centile and femur is on the 50th centile and the head is small? Can that happen? Yes, of course, you can have early onset microcephaly that can lead to fetal growth restriction. So what is the component of the fetal biometry that causes SGA? Is it the limbs, as in skeletal dysplasia, where you have a thanatophoric dysplasia, or you have osteogenesis imperfecta, where you have a normal head circumference, a normal abdominal circumference, but extremely short limbs? Or you have a symmetrically small baby where everything is on the 5th centile, and that is something that needs to be looked at for you to review as to what investigation to undertake later on. When you do the uterine artery Doppler, the most severe cases of placental insufficiency, you will have a placenta that looks abnormal because it will look like a ball rather than a disc. Because a normal placental morphology is to look like a disc rather than a ball, and in severe cases, you will have uterine artery Dopplers above the 99th centile, with, in the severe cases, demonstrating abnormality even in the umbilical artery. There is no point in doing an amniocentesis for this baby because you know that this is placental smallness. There is no point in doing an amniocentesis that increases the risk of any other adverse outcomes where you know that this is not an infectious etiology, because CMV cannot look like that and neither can skeletal dysplasia. So this is placental smallness, but you can consider as a part of your discussion with them. I won't discuss these differential diagnoses, but I will mention that the key for us, because the number of babies who are small because of severe smallness at 20 weeks are far and few. What is most important to discuss is a baby that is normal at 20 weeks but will become small in the third trimester at 28, 32 and 36 weeks, and how do you predict that? And again, if you look at the Royal College guideline, it gives you an algorithm. It gives you a flow chart at the end of the RCOG guideline that tells you that these are the risk factors based on which, if you have any of them, refer them for having growth scans in the third trimester. And the question to ask, is this a good policy? If you look at, and the risk factors that they have mentioned are age more than 40 years, smoking, drug, previous small baby, diabetes and so on and so forth. If I applied, I work in Kent, which is the southernmost part of England. It is one of the poorest parts of England. It is not diverse. We have predominantly a Caucasian population. We have a high rate of obesity. Our index of deprivation is through the roof. So we have a uniform, racially uniform population, but poor population. If I applied that formula to our population and followed that, I would have classified 40% or 45% of my population at high risk of SGA. But that cannot be. That cannot be. You cannot have half of your population at risk of having smallness. So is there a better way? And if you look at this model, and this has been looked at, so there was a study which is published in the British Journal, and we did that with with King's College. So King's and Medway, we combined the data. It was a study with Professor Nicolaides, and this is the study where we looked at if we had the competing risk model for screening for small for gestational age at 20 weeks using the uterine artery Doppler and estimated fetal weight, would we have a better detection of SGA and a lower false positive rate? And these ROC curves tell you the detection rate, i.e. sensitivity for 32 weeks, 37 weeks compared to the RCOG guideline. So the dots are the RCOG guideline. So the summary from these graphs is that the detection rate of RCOG guideline is 40% for the same false positive rate. And for the same screen positive rate, if we used estimated fetal weight, maternal characteristics, and uterine Doppler, our detection rate is almost 70%. So you double your detection rate and you reduce the number of women that you have to follow up. So not only that it is cost effective, but you use the model to screen the people who very much need the care and very much need the scans, rather than telling every 40-year-old mother that you are at risk and therefore you must have several scans and deliver at 38 weeks. No need. No need to do that. No need to terrorize the woman who has a BMI of 30 to say that you are at risk of stillbirth and SGA, because in our neck of the woods, 30% of the population has a BMI more than 30. I mean, we cannot keep doing scans every 3 weeks for BMI more than 30. It is physically impossible. So the screening model is accurate, and again we have also published. This is now, I don't remember, this is 10 years ago. So this paper is from 10 years ago. This is looking at risk factors in the maternal history, just like you have maternal age associated with trisomy 21. These are the characteristics that are associated with placental insufficiency and or preeclampsia and or stillbirth. And also the components from the 22-week scan. And you can see that in pregnancies that are destined to have an adverse outcome, you already have a small head circumference, you already have a small AC, even though it is not below the 5th centile, but it is on the 28th centile. And likewise for the female, and likewise for the uterine artery Doppler, and likewise for the placental growth factor. So if you have the means in private clinics or even in private institutions where you are doing a research project, and you can negotiate with the people who are sometimes supporting conferences to tell them that support the placental growth factor in 22-week scans to see whether we can identify that, this is exactly what you will find. That in pregnancies that will eventually become small, who are normal at 20 weeks but deliver a small baby, they will have extremely low PLGF at the 22-week scan. And if you use this model, you can stratify your population as to who needs the scan at 26, who needs the scan at 28, and who doesn't need any scans, and straight 36-week scan. So the summary, so we summarized the discussion from the 12-week scan, and we summarized the discussion from the 20-week scan here, is that examining the reason for smallness, whether it is the head or the abdomen or the limbs that is making it small, and check the combined risk for screening and stratify your population based on the Dopplers rather than just age and previous history. And the last few slides to summarize is the Dopplers. So the association of fetal Dopplers with smallness. And this is something that you have read and I have read and we all know. So when you find an associate, so the top one is a placenta that is normal, where you have 100% placental reserve, and that is how the umbilical artery is. When you have a high PI, where you mean you have a positive end diastolic flow, but the umbilical artery PI is above the 95th centile, you are working on 70% of the placental reserve, which means 30% of your placenta is not working. You are working on 70% placental reserve, and with that 70% placental reserve, you will have a positive end diastolic flow, but a high PI in the umbilical artery. When you have further placental insufficiency and your placenta is dead or necrotic or ischemic, even further, immunologically or non-immunologically, because there is impaired proliferation, then you will have a placenta with absent diastolic flow, and that is 50% of your placental reserve. And when you have a reverse flow in the umbilical artery, you are working on 30% placental reserve. So think of it when you are seeing those Doppler findings and making the decision about expected management versus continuation of pregnancy versus delivery, and depending on your discussion with your neonatal team, the chances of survival versus what the expected management is and what placental reserve that pregnancy is continuing. So that is one. And the same situation is for the MCA as well. Normal, high PI, low PI and lowest PI, you can see that the placental reserve is less and less when you have persistent redistribution. The question is that when you do a 36-week scan, how effective is it? On an average, if you do a 36-week scan, you will pick up 55% of pregnancies that are SGA, that are born anytime. But within 2 weeks, almost about 70 to 80%. So you will pick up 80% of small babies that are born within 2 weeks of the scan. I will skip this discussion about CPR because, or maybe I will just mention this one brief thing. There is a lot of discussion that CPR identifies hypoxic babies that are not small. So we looked at that in our data, and again, this is not 5,500 pregnancies, this is 47,000 pregnancies. This was now almost 6 years ago. This is in the American Journal, and we examined the performance of CPR in babies that are either small or big. And in big babies, the detection rate of stillbirth is 20% for a false positive rate of 5%, which means 80% of stillbirths that happen in big babies do not have a low CPR. So CPR as a screening method for adverse pregnancy outcome is not useful when you look at it in a screening context. If you have a small baby, that is helpful. But what is more helpful is to have these three things. So I have 3 slides left. This is third, and then 2 more to summarize what I have said so far. Our algorithm in our unit for management of fetal Dopplers is this one. So from 12 weeks to 24 weeks, the Doppler that tells you placental reserve is the uterine artery Doppler. The umbilical artery doesn't tell you anything before 24 weeks. The MCA doesn't tell you anything before 24 weeks. From 12 to 24 weeks, the artery that tells you placental reserve is the uterine artery Doppler, and use it to stratify your population or your pregnancies. After 24 weeks, the artery that first becomes abnormal is the umbilical artery, but you can continue the pregnancy because of the risks of prematurity, and you deliver based on the ductus venosus only before 30 weeks or 32 weeks. After 32 weeks, you will deliver based on the umbilical artery, and after 37 weeks, you will deliver based on the MCA. So those are the 3 Dopplers in an extremely simplistic format, rather than going with this strategy of CPR and various things. So summary, and again this is helpful, not just this is a long discussion with the fetal growth restriction, because this last slide and the last 2 slides is in itself a 20-minute discussion, but another time, another day in a different session. In early onset FGR, when you have an umbilical artery which is above the 95th but with positive end diastolic flow with a normal MCA and normal ductus venosus, how often do you see the patient? See them once a week. Number 2, if you have an abnormal umbilical artery and an abnormal MCA and a normal ductus venosus, you have to see them twice a week, but along with CTG. And if you have all abnormal before 30 weeks, carry on scanning them alternate day with ductus venosus and deliver when the ductus venosus is abnormal. And then it tells you the gestational ages and which Doppler to use for delivery before 30 weeks, after 32 weeks, after 34 to 36, when to give steroids and magnesium sulfate. The international recommendations for prevention of neuroprotection in small babies recommends that you will give magnesium sulfate definitely if you are delivering before 30 weeks. Consider it strongly before 32 weeks, but after 32 weeks not so much. If you have a baby, and again, I would say that if you have a baby below the 5th centile, the corrected gestation is 2 weeks before. So if you have a 32-week baby below the 5th centile, that baby is like a 32-weeker. So if you have a baby between 32 and 34 weeks below the 5th centile, give magnesium sulfate. That is the magnesium sulfate. And otherwise, this just summarizes everything that we have said so far. And I will stop the questions.
Thank you very much for this interesting talk. And I believe that this subject is one of the subjects you were aspiring to focus upon when you become the Minister of Health in New York. Maybe we have the time for one more question.
دكتورة
I'm very impressed with your talk, but can we go back to the Doppler one, because I think it's a very important learning.
Which slide, sorry?
How do you classify your treatment based on this one? Can you elaborate more? So the uterine artery, and here you're trying to get the SGA or fetal growth restriction, right?
Yes. So
if you can just work us through the algorithm.
I will. So this is the slide that I skipped. So this is the slide that tells you that from 12 weeks to 42 weeks, which is the Doppler that tells you placental reserve. In the first 24 weeks of pregnancy, the Doppler that tells you placental reserve is the uterine artery Doppler. From 24 to 36 weeks, the Doppler that tells you placental reserve is the umbilical artery. And the Doppler that tells you placental reserve after 37 weeks is the MCA. So this is the Dopplers. So this is the first Doppler that will become abnormal in placental insufficiency. First 24 weeks uterine, 24 to 36 weeks umbilical artery, and 36 to 42 weeks MCA, with everything else being normal. So this is the first Doppler abnormality reflecting placental reserve in pregnancies with placental insufficiency across gestational age. And then this slide was the Doppler to be used for delivery. So the first 24 weeks nobody will deliver anyone, but again it is to show that Doppler of choice to identify pregnancies at risk is uterine artery Doppler in the first 24 weeks, and then between 24 and 30 weeks you will deliver only if the ductus venosus was abnormal in a small baby. Between 30 and 37 weeks, you would deliver based on the umbilical artery. So if your umbilical artery had a reversed flow, you will deliver even if the MCA and the ductus was abnormal. And after 37 weeks, if you have a baby that is small or not even small, but you have persistently found a MCA below the 5th centile, and our protocol is that if you have a baby on the 30th centile and you have low MCA, we send the woman for a walk, call her back after 2 hours. If it is still low, we do a CTG. If it is normal, we call her back in the evening. So over 24 hours, if this baby continues to have a low MCA, she is for delivery.
If we go back into the curve, the ductus venosus, as a cardiologist, we know that abnormal for us, ductus venosus is an A-wave reversal. And what you're showing here is there's no A-wave reversal. And what is abnormal here? The PI and the ductus
It is the
venosus?
PI. So this is the slight difference. And again, I do not know whether the rest of the audience has the stamina left for this discussion or not, but because you have asked me this question, ductus venosus in fetal life is exactly the same as jugular venous pressure. What ductus venosus represents, it represents right atrial pressure. And the right atrial pressure represents right ventricular pressure. And the right ventricular pressure at the end of the diastole reflects how much of your myocardium is there. So you will have an abnormal ductus venosus when you have a myocardial hypoxia. Now the ductus venosus, by the time you have 3 waves, A wave, C wave and V wave. So when you have the A wave, which represents atrial systole, by the time you reverse that wave, you have been waited too long. So my personal opinion is, when you wait until your ductus venosus has a reverse A wave, that baby's myocardium is already hypoxic. So when you deliver that baby and that baby goes to the neonatal unit, for sure that baby is going to be on dopamine, dobutamine and inotropes. So the key is identifying, is the ductus venosus persistently abnormal with still myocardial reserve? Does that make sense? But we can have this discussion over coffee. I don't want, but I hope I have answered your question.
Can we have a couple of very, very quick questions, me and
Of course.
I know.
I don't want to be
You know,
delaying.
we don't have charts for growth in this region.
Okay.
So we're depending on the international charts.
Yeah.
And definitely, sometimes we're faced with small babies. I mean, because the charts are different.
Yeah.
So, but the Dopplers are fine. So we have lots of small for gestational age, if you like, rather than severely or restricted growth restriction.
Yeah.
So I would like to hear your views on that. A brief answer, and then I'll give it to some.
Yeah. I agree that to a certain extent there are small differences based on the population, but as I said, that even in your population, you should have the baby in the normal range, not small, in the normal range up to 22 weeks. The baby may become smaller and go on the 10th centile on the international charts at 30, 34, 36 weeks. But so long as you have a baby that shows serial growth, so long as there is consistency of growth, and so long as there is normal amniotic fluid and normal Dopplers, I wouldn't worry about that baby. In England, what they do, and in many places, they are customizing the babies based on their ethnicity. So if you have a black or a brown woman in England, they are saying that we need to customize based on your color and move the dot from the 10th centile to the 58th centile. And is that customization to adjust for ethnic differences helpful? It is not helpful. I think it is probably counterproductive. And why do I say that? Do we all believe that human pregnancy is 42 weeks because there are people who go to 42, 43 weeks in Scandinavian countries and in England many a times? And is that okay? I think that the whole issue of discussion of how long is a human pregnancy, what varies is not the growth, what varies is placental reserve in different populations. So Asian and African placentas are different than Caucasian placentas, and they will behave differently at 41 weeks than a woman from a Caucasian background. So to move that dot up and down and to treat them the same, to say that you need to go to 42 weeks because you're in the 40th centile, is doing them disservice. I would rather keep that baby on the small centile and make sure the baby is following the same growth trajectory, but with normal amniotic fluid and normal umbilical artery and normal MC, and call their constitution its own.
Ask question.
Last question, promise, short one. Thank you very much for you too. Just to clarify, you said we're delivering based on the ductus venosus changes. So what you're saying is it doesn't really matter whether it's an early change with the fertility index above the 95th percentile versus an absent or a reverse A-wave. You deliver all at 30 weeks?
Yes, I would have a low threshold for delivering with a PI above the 95th centile if I'm sure that it is above the 95th centile. Because what does that mean? I have a small baby with an abnormal umbilical artery with an abnormal MCA already. Because you cannot have ductus venosus changes in the absence of MCA and umbilical artery in an early onset IGR. So if you have a small baby with an abnormal umbilical artery with an abnormal MCA, that baby is redistributing at its extreme. And when that baby, after all of cardiovascular redistribution, is now having increased PI in the ductus venosus, that I am understanding as a baby that is at the limit of compensation. I push that baby any further and that baby will decompensate. So I would rather deliver that baby with some myocardial reserve rather than no myocardial reserve. So there is that discussion even in the Truffle 1 study about whether you wait until the A wave is reversed and whether you have waited too long, or whether you deliver when you are absolutely sure that your intra and intra-observer variation is minimal and it is high PI above the 95th centile, and your A wave that is usually very chunky is hardly there, but it is positive. I will deliver on that. Because if you look at any good neonatal unit, if you have optimized this baby with steroids and magnesium sulfate and this baby weighs 1,000 grams, and if you have delivered that baby with a normal pH in the umbilical cord, that baby should go home.
Yeah.
But of course,
So,
the biggest elephant in the room that we haven't discussed is who should do that cesarean section. Because it is not some inexperienced obstetrician to do that cesarean section at 2 o'clock in the morning. It should be a senior, as in not the most senior most obstetrician, but an experienced obstetrician, because that cesarean section at 28 to 30 weeks is not easy. So there is an element of intrapartum hypoxia that is caused during the operative birth. So that birth for that growth restricted baby with abnormal Dopplers also has to be done carefully to give that baby the best chance. So again, that we haven't discussed.
yeah, but just last one. So if there is a late change the A wave is reversed, is there a place to deliver before 30 weeks? Would you,
Yes, I would. Yes.
would you do that at 28 or 29 weeks?
I would.
You would.
If the ductless wave is reversed, I would deliver at 28 as well.
28.
Yeah.
Okay. And late and early change up to 30, you wouldn't go beyond that?
Yeah.
Okay. So that's
Thank you,
different to
Dr.
the
Sam.
college guideline. Yeah.
Thank you.
Thank you very much.
It's such an interesting topic that we can talk for another 3 hours, but we need to stop. Thank you.
Now we have a big event for Samsung, please. Then Alexa.
Dear partners, distinguished guests, ladies and gentlemen, Assalamu alaikum. A very warm welcome to all of you to this special symposium organized in collaboration with the Jordanian Society of Obstetrics and Gynecology. It is an honor and a privilege to stand before such a gathering of experts, innovators, and dedicated OBGYN physicians, all committed to advancing women's health in Jordan. Allow me first to introduce AMSA, Arab Medical and Scientific Alliance, one of Shuqairi Group companies. For over 75 years, Shuqairi Group have been serving the healthcare sector in Jordan, and AMSA has been a leading force in bringing advanced healthcare technologies to our people. Since our earliest days, AMSA has established deep partnerships with global healthcare companies, among which Samsung Healthcare stands prominently. Our partnership with Samsung Healthcare extends to over 25 years now and counting. Through AMSA's comprehensive portfolio that includes, in addition to ultrasound medical imaging, diagnostic and therapeutic equipment, hospital infrastructure solutions, laboratory solutions, digital healthcare solutions, and more. We have served hospitals, clinics, and healthcare institutions across Jordan with commitment, integrity, and quality. This long-standing partnership with Samsung Healthcare has allowed us to introduce cutting-edge ultrasound and imaging solutions into our healthcare system. Tools which empower you, our physicians, to improve diagnosis, treatment, and outcomes for mothers, babies, and women at every stage. I would like to take a moment to introduce and thank Ms. Mira, Area Sales Manager for Samsung Healthcare. Mira, your presence here today is deeply appreciated, and your continuous support, both strategic and practical, in facilitating this partnership has been essential. Your efforts to ensure that our OBGYN community has access to the latest innovations, training, and follow-up support do not go unnoticed. Thank you for joining us and for being a vital bridge between Samsung, AMSA, and the medical professionals in Jordan. We are also especially honored that Dr. George Haddad has joined us from abroad to participate in this event. Dr. Haddad's international expertise and experience are tremendous assets, and his role today will help us to unlock the full potential of Samsung's newest premium system, the HERA Z20. Having you here, Dr. Haddad, enriches our discussions and ensures that what you share will have the benefit of a global perspective aligned with with local needs. Now, for all of us who are interested in what the HERA 20 brings to the field of obstetrics and gynecology, this ultrasound system represents Samsung Healthcare's newest premium innovation in women's health imaging. It offers exceptional imaging capabilities in 2D, 3D, and color Doppler modes. I will not talk much about what this beautiful system brings to your practice, but I will leave it to Mira and to the live scanning to do all the talk. As OBGYN physicians, you know better than anyone that early, accurate diagnosis, effective monitoring, and compassionate care makes all the difference. The HERA Z20 promises to help us raise our standard of care even higher. In closing, I want to express my deepest appreciation to the Jordanian Society of Obstetrics and Gynecology and its valued board and members. Thank you for arranging this respected event. To AMSA's entire team for maintaining this partnership, for ensuring that we have access to technologies like HERA Z20, and for supporting our medical community through service, training, and trust. I hope that today's symposium will be a fertile ground for knowledge exchange, for learning, for challenging existing practices, and for fostering collaboration. May we leave here inspired, informed, and emboldened to provide even finer care to our patients. Thank you all, and I wish you a productive, engaging, and inspiring evening. Thank you. Allow me to introduce Mira to talk more about the HERA Z20 system.
Hello, ladies and gentlemen. My name is Mira Oh. I'm the area manager from headquarters, Korea. For Samsung, I'm really honored to be here. And dear Dr. Abir, Dr. Maher, thank you very much for having us today in this place. And I'm really glad to introduce to you our new premium OBGYN system, HERA Z20. As you may know, Samsung is strong in the area of electronics and artificial intelligence, telecommunications, and the Samsung structure itself is divided into two parts. As you can see, it's device solutions and device experience. So in Samsung ultrasound systems and Samsung healthcare equipment, we try to utilize this experience and the knowledge we have from these areas to develop the edge of technology ultrasound systems for you. And I'd like to highlight an example of how industry and medicine can come together to drive meaningful innovation. And in this case, I would like to tell you that Samsung is collaborating with Samsung Medical Center in Korea, which is our kind of test bed for the new technologies. And we try to listen to the actual users on the field, try to understand what is their actual needs. And of course, in fetal medicine, we see that there are some challenges. And the challenges we now understanding. First is diagnose abnormalities earlier with precision. Regarding this, we addressed with our new software beamforming technology. Also, the tools we provide like 5D CNS or an Easy HQ to enhance the diagnostics. The second challenge, as we see, is improve efficiency and reduce operator dependency. Here, we develop new AI-based technologies like Live View Assist, which we believe will, with the automated measurements and annotations, reduce the operator dependency and make the workflow much easier for you. And the third one challenge we think is the seamless workflow. Workflow should be working for you. It should make your work process much easier. And here we are trying to apply the best of our ergonomics on the system, on the probes. So further, I will discuss in details. So at the center of Samsung's approach, we are trying to use these three pillars that will help us to develop new edge of technology ultrasound equipment. The first is, of course, AI-powered technologies. Who could think like 10 years ago how AI will change our lives today, right? Today, and I don't know how it will get changed after, I don't know, maybe 2 or 3 years, but we think that it will affect our lives tremendously. And next one is a breakthrough imaging powered by new technology. In this new platform of ultrasound systems of the premium grade, we are using totally new beamforming technology that is different from the previous technologies that we had. And the third part is ergonomics. We know that you are working with the system during the long hours, and we want that our system will bring you the most efficiency, the most comfortable position, and of course, the very easy use. Okay? So ladies and gentlemen, let us talk more about the HERA Z20, our new premium OBGYN system. So we thought a lot what we can do to make the breakthrough in the imaging technologies. And from now, I will just show several images, just introduce what is the capability of the Z20. Just in short. Okay, here we have the first trimester scan using HERA Z20. This image was taken with the endocavity transducer. And some images of the second trimester fetal heart. As you know, this is the stage where detailed cardiac evaluation becomes essential, and image quality makes all the difference. And now we believe detecting multiple myoma cases will be much easier with Z20. And of course, user can easily recognize the tiny ventricular septal defect using Z20. And there is technology we call MV flow, is to detect the tiny micro vessels where this technology can be used. Like cases here, it can be used in the brain, in the fetal heart, and circulation in the placenta, the liver, portal vein, the kidneys. And why it matters? Because with this technology, it will help to detect subtle vascular changes that standard Doppler might miss. And some also another examples of using MD flow, for example, for fetal brain case. And we also have this new 3D image technology. On this side, you see the conventional 3D technology. But with the new AI-based 3D technology, as you can see, the system will be automatically segment the organs, and you can easily segment the parts like placenta, baby fetus, umbilical cord. This is one case of the clubfoot, which was detected using the easy volume features. And of course, besides obstetrics, we provide several tools that can be also used in gynecology. Like here, you see using the feature Crystal View, imaging and for uterus, also fibroids also can be used detect easily. So in the beginning, I mentioned that in Z20, we are using totally new technology called software beamforming. So how it was involved? In general, it was using the hardware beamforming. What is hardware beamforming? It has very fixed beamforming bandwidth. Next step was software beamforming, but still it has limited bandwidth. But with the new Samsung software beamforming, we have much faster frame rate and tissue contrast enhancement, and of course it will have better resolution with the contrast. Okay, so of course we can't miss talking about AI technologies, And in Z20 premium system, we have big, wide portfolio of AI features based targeted for obstetrician cases and for gynecology cases. And one of the key technologies that you can experience in Z20 is Live View Assist. In this case, doctor will just need scan. System will, for you, instead of you, select the best image out of all the scanned images that you did and do the measurement automatically and do the annotation. And you don't need to push any freeze button, no on any other measurements. The system will do all these measurements automatically. Also, we provide the easy checklist. So when you need to make a long list of check list like for first trimester, this one will help you not to miss any details. And of course, one of difficult parts, I'm sure in fetal medicine, is a heart, fetal heart. So we also have our feature, fetal heart assist feature, which we sure will much make your process of detecting the fetal heart malformations easier. Okay, the easy volume I already mentioned. And also we have easy volume measurement, which automatically will measure the volume, for example, of the fetus, of the placenta, or the fluid. And we have this specific feature we call portrait view. It's not for diagnostic purposes, but I think that just with pressing 3 points, you would be able to remove all the tissues, all the masses that in front of the baby face, and to provide to the mother or to the family beautiful baby picture. Okay? So, ergonomics. As I mentioned, we care about our users, and we, using Z20, evaluated across the 6 countries, and more than 120 users evaluated our system, and we passed 37 standards, which confirms that our Z20 is friendly, user-friendly, and tries to make your ultrasound scanning process much easier. And this is also unique for Samsung Medicine, that for the first time we are launching now to the market thin cables, because we know that during long hours of working, you need to hold the probe like for many hours, and sometimes it can cause some injuries in MSK. But with this thin cable, we made the weight of the probe much lighter, like more than 30-40%. So we hope that also will be very helpfully utilized in your daily practice. Okay, so dear doctors, we want you to be you, and Samsung will adjust according to your requirements. Thank you. And now, as you may notice, we have our main topic of the day. So I would like to invite to our stage our dear Dr. Abir, dear Dr. Maher, Dr. George Haddad, to help us with unveiling the system.
ارفع الستار.
I hope you're ready to meet our new ultrasound system
we already too late, so we give 10 minutes just for each, please.
I'm professor of training gynecology at the University of Parma, and from next month I will be professor of aesthetics at the Catholic University of Rome and lead of the Second Unit of Fetomaternal Hospital in Rome. I'm so thrilled to share with you my preliminary experience with this new extraordinary ultrasound machine, the new Z20 system from Samsung. I had the chance to work a while with the machine, and I really was impressed by the high quality of the ultrasound machine, by some new specific software which may enhance the quality of the image, really make enjoyable the ultrasound scan to the patient, to the practitioner, and so about specific program that optimize the quality of image. The EZ is for easy EZ structure, is optimized the type of image according to the testing. The image volume is optimized the activation rendering of the volume with 3D system according to the type of structure that we want to render. The image flow is optimized the doctor imaging in a specific vascular district, and of course, I cannot forget about the live velocity, which is this innovative, I would say revolutionary way of doing an anomaly scan thanks to a system which is based on how it automatically extracts the anatomical plane which are recommended by the comprehensive anomaly scan that is throughout the station. So I'm really honored to have the chance to share with you my experience, and I'm looking forward to receiving feedback from all the other practitioners from now on throughout the world.
Hello, my name is Elena Sinkovskaya. I'm professor of obstetrics and gynecology, director of ultrasound research and education, and the program director of the Fetal Cardiology Fellowship in the Division of Maternal Fetal Medicine in Macon and John Rock Virginia Health Sciences at Albany University. And today I'm very excited to share my experience.
So the first lady is with a previous history of syndromic baby, and in this pregnancy the nuchal true sensitivity was 5.8, and she's now 26 weeks. There is a brightness echogenic left ventricles and pericardial effusions around 4 centimeters. So Dr. George, in 7 minutes we need quick scan to the heart, just.
So, just I wanted to explain to you that this machine is coming like a lot of other machines from Korea, and for sure they have done the preset, as you see in the hospital in Korea with the Korean patient. So, because it's a new machine, the preset are for Korean people. When you buy a machine like this one, you have to choose a preset heart from Korea, and then to change it with the Jordanian patient. So because we have to explain now heart exploration, this machine have a lot of artificial intelligence, but what I preferred in the machine, it's the amelioration that they have done with 2D images. As you see here, for example, for heart, you have no more focus for the heart. In fact, the probe do the focus automatically for the heart, and you don't have to choose your focus. And then you have to as I told you just first trimester also, but in the same thing, you have to use the digital zoom like this. And as I told you now, the left of the baby is here because it's a spheric presentation, and the back is on the left of the patient. So the left of the baby is here. So you can see here the stomach, you can see here the aorta on the left, and you can see here inferior vein cave. So this is the first step. It's like this hotel. In -1 in the parking, you can find the stomach, the aorta, and the inferior vein cave. And when you are coming to the ground floor, you have the lobby. So I'm going to the ground floor, and the lobby with the fourth chamber's view. Have you seen how it's very clear and very quick? You can see here the apex. So on the left, you can see here left ventricle. Why is left ventricle? Because he's taking the apex, and they have the mitral. What's the difference between mitral valve and tricuspid valve? The mitral has 2 valves, and the tricuspid has 3. So here the insertion of the mitral it's a 90 degrees with the heart, with the myocardium, and here you have like a Y, like why? Because you have 3 in the tricuspid. And as you see here, very good. You can see here pulmonary vein. You can see here left atrium and right atrium. And look here, you can even see the coronary sinus here. And you can use the color as Mira explained to you, and the color is really very nice, as you see here. And you can see here there is no tricuspid regurgitation. The red is coming from atrium to ventricle, and the blue from the ventricle to the aorta. Okay? So let us return to 2D, and now you are in the ground floor at the lobby. You have to go to the first floor, which the first vessels, arteries leaving the heart is the aorta. So I'm going on the first floor, and look, I can see very well the aorta. As you see here, mitral aorta and septum aorta. There is a continuum between the aorta, the septum with the aorta, and you can see here the aortic valve. You see here the aortic valve? Up here. Okay? So this is perhaps the aorta. I'm sure it's aorta, but you cannot conclude before seeing the pulmonary artery. Okay? So I go to the second floor, and the second floor I can see the pulmonary artery leaving from right ventricle to the left. So you can see here, you see here pulmonary artery dividing to the ductus arteriosus and the right pulmonary artery. You can see here. Okay, this is the short axis plan, and you see here pulmonary artery going to aorta by the ductus arteriosus, and this is the aorta here. Okay, and then you go to so now I'm sure that aorta is on the place and pulmonary artery on the place, and I have to see the third vessel's view. So it's one more level. So you can see here pulmonary artery, aorta, and superior vein cave. And if you are not sure, you can use the color as Mira explained to you. Look, you have blue. So up, and as I show you this morning with the 2 fingers. So the biggest one is pulmonary artery, because he's coming from the right ventricle, and the right ventricle is anterior, and the aorta is here. This is what we call the V-shaped sign. Okay. And then I continue, I stop, and I continue here, and I can see here the vein coming from the left to the right, coming to the, coming from the left to the vein cave, to the superior vein cave, and we see here. And if I continue, I can go to thyroid and trachea here. Okay? Yes, we can see here. Trachea is here. Just because he turned a little bit. This is the trachea. You see trachea? And this is, look, carotid and jugular vein. Okay? So this is the rooftop of the hotel, if you want to take a beer. This is your trachea, and we see here the cricoid cartilage. Okay? So I return just 1 minute because you explain about thymus. Look, I have the 3 vessels view, and you can see the difference between, okay, you can see difference between pulmonary area, and this is the thymus. You see? It's a huge thymus, it's a normal thymus. Okay? Yes, it's less dark and more glassy. You see, less like a glass. And here, you have a very little artery here. This is mammalian anterior artery. Yes. Okay? So, you see, it took us really even 4 minutes, 3 minutes to be sure that the heart here is normal. Okay? Now, you can do a lot more things, you know, you can see. But look, I return just to remember you some things. For example, yes, look here, you can see, yes, here, look, you see the difference between tricuspid valve and mitral valve. You see that you have like a Y because there is a 3-1. So it's like a lambda sign in mitral pregnancy. You see? So this is very important because always, as we told you this morning, valve go with the ventricle. And you see there is a difference of insertion. The tricuspid is more apexial. Okay? No, it's not. Why? Look, why I'm sure there is no pericardial effusion because there is a difference between here is normal and you see here more. Logically, when you have a pericardial effusion, you have the same all around.
Dr. George, just in 1 to 2 minutes, just could you explain the cause of brightness of the right ventricles and the mild pericardial effusions? Is it normal because she is with a previous history of... It's normal. Previous history with cardiac effusion. The first baby.
It's physiologic because really it's less than 3 millimeters.
And it's normal.
Okay. Okay. And just for the patient, I want to show you something. There is no focus.
Okay.
Just I want to show you okay, look position, okay. So we can do 3D. Okay, no.
It's like normal, but for
3D, okay. Going here. Okay. So you can see here, and we can put just one image, and they speak about portrait view from here to here and to here. Okay, and this is the portrait view. Okay. Okay. Just okay, another time like this. Okay, up. I have the. Look, I make this look little bit. You see here the arm, and you see a little bit of placenta. Okay, so I will use easy volume. Easy volume. He will give a color for every single thing. So I want to take off, for example, the arm and the leg. Look, I just do this, and it takes off the arm. I wanted to take off the cord. It will take off the cord. And this is very interesting because in the future we can take an image with the placenta and with the uterus.
Time over, just Dr. George.
And we can see if there is a nacreta or not. Okay, so this is very nice for the future. Okay.
Please. Okay. The next lady. واصل معي ان شاء الله العياده عشان اعطيك موعد مروا على اعطي موعد. The next lady, she's not sure about the last menstrual period, and based on the head circumference, we give her the estimated date of delivery at the 10th of حكينا February 10/2 موعد ولادتها based on head circumference. She's referred due to CT exposure and X-ray. So a quick anomaly scan, please, in 10 minutes.
زي جراد والكري والسنجل مالتيبل سي تي سكان وكذا كل واحدة بتكتب.
George can do it in 10 minutes.
Okay, so we are in so as we
حنحط الاستيميتد ديت 12/2 او 10/2 sorry, because she's wrong date and there's discordance between last menstrual period and head circumference. She doesn't know, but
اخر هذا ثلاثة خمسة اخر هذا 10/2 موعد
yes
هذه 3/5 3/5 من اخر هذا.
So إذا 21 بس لحتى نتأكد to be sure. Look, I just have this. طلع هلا أنا بطلب. I just have to leave this and ask him to auto measure. So he gives me BBD and PC. I haven't touched anything. I just auto measurement, and auto measurement gives me, as you see, the H, so I can also change and take myself, and you see it will be the same thing. It's 20.5. Okay. Okay. هذه إذا يا بطلب منه أنا auto evaluation يا أنا بعمله. شفت إنه I take more time and to have exactly the same answer 177 millimeters. Okay. No, like أنا عم بعطيه. تصور هلا I cancel everything. Look, I cancel تبع هون. Okay. I cancel. I ask him auto measurement. This is II, and she give me 178. I have found 177.8. So it's the same thing. But you see that here is more quick than me. Okay. So to be sure, I will take the cerebellum and I will do the same thing. You see, this is, oops, excuse me. Cancel, So I stop the image, so you have cine loop. So I'm asking just to have the cerebellum and I can ask for cerebellum and auto measurement, and you see, you measure the cerebellum. Okay, لوحده. I have touch. Okay. And to be sure that the cerebellum is good, I can do the IOD, because at this term the IOD have the same measurement as the cerebellum. So look up, I will take the IOD from here to here, and look, the same thing, 21 to 21. we can take الفيدر هارت. اوكي اذا بدكم تغيروا الصوره انا معود اسود وابيض بس اوكي هلا اوكي هلا مش رح اعمل لكم زي شيء بس تطلع على السريع اذا في المالفورميشن في الهارت مالفورميشن. شفتوا الراس لتحت. اوكي بتعرف اذا بنت صبي ولا بنت؟ بنت بعد بنت ما غير. I said that it was a girl. Okay. As you see here on the left, we have this. You see the three vessels view? The V shape? Okay. And they continue between our there is a septum defect. No, septum defect. The heart, there is no problem in the heart. Okay, نحاجة بس على السريع نشوف ال اوكي شفت الأورطة؟ I can see الأورطة. وإذا بنشوف الفيكتوس arteriosus you have to go from more anterior. This is the right ventricle, pulmonary artery going to the aorta. You see it up, okay. And the stomach is here. As I explained to you, just to show you, do you see here? We can see here the esophagus. You can see this up here. You can see it up. Can you see the esophagus? Double line, double white line. You see? The trachea is here. So you see here is alive. So شفتوا الاسوفيجس؟ شفتوا الاسوفيجس؟ هون هون. دائما هون التراكيا. اوكي؟ هيدا هون الكلية وهيدا التايمس. اوكي؟ هيدا الكفر. اوكي؟ ديكتس فينوسس look هيدا الامبليكال vein. I'll have color and look dictus venosus here it's here up هيدا هو عم بيعمل اليازم. ايوه up you can see اليازم here up yes up. هلا منظر الظهر بيبين على عم يتهيأ بتغير شوي قبل بين هذا اوكي بس وين عم لازم تقبل بس بدي انفيرس وين اوكي 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 هلا والليفر تمام. شفتوا الليفر ما في شيء بس لفرجيكم شغله ثانيه كمان. هون بتشوفوا الاستومك. اوكي هون السبلين. اوكي وهي اب اكسكيوز مي هيدا هون البنكرياس. ايه كيف لكن هيدا you can go from here to the thymus up here's the thymus هيدا التhymus هيدا التhymus. لكن الفرق بين anterior this is the three vessels هيدا anterior هيدا الpulmonary. there is a difference between pulmonary and thymus. اوكي في فرق مهم. اوكي هيدا على السريع. اوكي هلا الفيمر you have to be parallel. Look you have to be parallel to the probe. Okay يعني you have to take just the diaphysis. Look I have to say femur and auto measure. Okay you give me 32 it's 20.2 it's okay. And you see everything you have to take just diaphysis, not the epiphysis, not the metaphysis. Okay, you see the difference? I cannot really, you cannot take the femur like this. This is an error to take it like this. Why? Because you can see the metaphysics in the same time, and you have a rectangle, and the diagonal of a rectangle is more than the side, like Pythagoras said. Okay. بدون هيدا بكتب من هون بتعمل بدون هيدا بس الديافيزيس هيدا ولكن هيدا الفيمر you don't have to measure this one, always this one because he's and then you can see up the two feet وتبقى فيمر هيدا بكمل على جعلنا على واذا بدكم تشوفوا بال 4D يعني 3D لايف على الجيران اوكي حط صوره واحده شفتوا انه اللي فرجيكم اياهم على انه ما في جاب فوت اوكي حاط رجع على رجل هي بنت اوكي
So the abdominal circumference, Dr. George,
abdominal circumference
to ensure that the date is known.
abdominal انا عندي الستومك هون عندي هون الامبليكال فين وبقولوا لحتى ياخذ بس الادرينال جلاند ما ياخذ البريماري بقولوا هاي لا لان بعد ترشيد السيرنا هون الامبليكال والادرينال جلاند اوكي والستومك تحت بس لانه الستومك ايام you don't have it اوكي اوكي هلا اذا نعمل الهيد بالارتفيشال انتليجنسي هو انا عم بعمل هيك بياخذها لوحده بس انا بقطع اوكي ايه هو بياخذها اوكي شفت 20.3 زيت الشيء كله صار زيت الشيء اوكي كل شيء شفتوا البنكرياس بشوفهم منيحه البنكرياس هذا الابيض اللي هون اوكي والسبيشال بدي افرجيكم الكدني شفتوا الكدنيز هذه وهذا الكدنيز هون اوكي السبلين ما فيها يعملها سبلين دغري على طول هون لا ولا السبلين اوكي اذا بتحطوا الكلر رح يحط لا بنحط الباور بنحط اسكيو نروح على السبين طلع هيدي السبلينج ارتري يصير السبلينج ارتري going to the spleen اوكي شفتوا على البنكرياس the spleen artery if you remember your anatomy it's going like waves on the pancreas بدكم تفرجوا شو عم بغير البيشنت على امك هون اوكي بفرجيك بس على البلادر سبلينيك على البلادر انه كيف اوكي طب هيدي تو امبليكال ارتري اوكي هلا البلادر بعده يعني فضي بس you have also a V shape it's not parallel it's a V you see the V it means that the bladder is here if there is no bladder if there is a bladder extrophy you have it very parallel okay and yes we have to do the Doppler for sure you can do the Doppler here in a car okay and you ask to calculate so you say umbilical artery auto so you have done the auto okay and you can do it also not auto it's mean and the index the resistance is how much PL how is
So, Dr. George, could you get a picture for the face and show the upper extremities to reassure her there's no visible abnormalities due to CT?
Okay. هلا الابر ايام ما فينا نحطهم اثنيناتهم سوا بنحط you can devise بتحط وحده على اليمين اوكي وبتعمل another one on the left okay like this you are sure that you have the two okay you see here you have one and here you have one that is the first thing you have to do the two images and then okay you can see here the fingers okay تمام اوكي بعدين بس بدي فرجيك اب الفيس ماشي اوكي اب هلا الديفرنس ال 3D he take more you have more information but 4D you have it's in real time يعني you can see the baby moving in the same time okay احلى بس you have less information اذا بتوقفي بس for the parents it's better to have 4D and then 3D okay ايه اخذنا اوكي بس لحتى اعملها هيك go to the code review او حتى بالفرق الموجود
So, time over.
Okay.
Third case, Al-Anoud. Get ready, please. So, just show us the chart, please, to ensure that the growth is, the heartbeating is normal. As we see the growth tense in time. It's a small baby, yeah? If the dating is correct.
So in this situation, I think that you have to see her in 2 weeks and to see the evaluation. Thank you. And to see the evaluation in 2 weeks. But the Doppler is normal. The Doppler was normal. Okay. بس لكن غير البيشنت حط finish patient and exam and new patient حتى التست test is a third patient.
So the next lady is Al-Anoud. Al-Anoud is with the previous history of dead baby due to genetic mutations. The mutations is gene 26 heterogeneous, and the interesting thing, when do the test, the result came back with heterogeneous, and the baby after birth we found affected with hypertrophic cardiomyopathy, dilated hypertrophic. Now she is, I think, 19 weeks. Can we predict the cardiomyopathy or contractility? She is asking because she now there's a debate and denies to do genetic testing.
So this one here, we just try. Yeah. So usually we start outside and we try to get the umbilical artery. This is the protocol that we usually, and we have to get a free umbilical cord, and then we do the. الصورة مش حلوة كتير يا جماعة. عادي يعني. I want it to be crispy. I want it to be very crispy. So Please. Yeah, we always start with umbilical artery because we want to get the heart rate and we want to make sure that it is sinus rhythm. So when we talk about sinus rhythm, we look here and we find that every beat is followed by another beat. Every beat is followed. This one is coming a little bit early. It could be premature ectopic, but we're not sure. This is not an optimal view because the umbilical vein is not there. But at least we can try. Now, if you don't get a good one, you just do a manual tracing rather than O2 and get one value here. So try and get this one. Yeah. I don't like auto tracing if the manual and you take one. Yeah, you take one because you want to decrease the you want to decrease the error. If you do auto here, you're not going to. So do manual tracing. So where am I going to start? And then you try as much as possible. And then here, okay. As a cardiologist, we usually look at the heart rate. So what's the heart rate here? So this is not set for a heart assessment because we're doing a general exam. But if we go for fetal heart, it will automatically give me. Now here, I can get the PI 1.36 and I have to keep it in mind. As a cardiologist, we do 3 PIs, umbilical artery, MCA, and ductus venosus. Now, we try to localize the heart. We're not very happy with it. So what we do, we try to do some screening in a way, so we make the sector smaller. So that time, the image is not very good, okay? Maybe, actually the lady is not very, she should be, the baby should be photogenic because she's not obese. So what we try to do here is we try to get the heart as much as possible, and we try to, can I go to the heart or should I just do it like that because I'm not used to this machine?
You want the heart? Yes. Okay.
I had a preset. Yes. If I'm not happy, what I do is I try as much as possible to get simultaneous imaging. So give me simultaneous, give me another one. So what I'm seeing here, I'm guided by the color. I see 2 ventricles here and I see 2 atria, but here the image is not very clear. So I cannot really judge that this is intact, but with the color there's no crossing, so the intraventricular septum is okay in this case. And I could see the atria as well. So still I'm not happy with the imaging. Either the machine, either me, whatever the position of the baby, but at least we should try as much as possible usually to get a better one. Yeah.
Gluten to the left or right, Anu?
We're trying to show you the difference between the pediatric cardiology protocol and the part of the anomaly scan. So I'm not happy with this image, so I'll just step out and let Dr. George continue. And I think here
But-
the problem is either
So the contractile is normal and there is no cardiomegaly. It's
no
just
cardiomegaly.
things.
Wait.
طيب بس
Wait,
please
just a
Dr.
second,
George.
just a second. Do you see the red color crossing here? Where's the arrow? Okay. There's crossing at the, you see this one? I want to have yes. So here, this is the interventricular septum. And you see, there could be an apical muscular VSD crossing across. But you cannot say, just depending on the color, you have to see the simultaneous image where there's a drop back here. But at least there could be, and these are the ones that are harmless and they could be missed. I think.
Please, Dr. George, just in 4 minutes. I know it.
Your question is very nice. When you buy the machine like this one, if you take if you take a 3D 1 to 10, it's better to take a 2D 1 to 6 or 1 to 5. If you take 1 to 10 in 2D and 1 to 10 in 3D, you have the same image. So it's better to take a 1.5 or 1.6 and 1.10 for ايه ده شو بدي اشوفه طلعت فيه اوكي اوكي هلا هاي الفورس شامبرز فيو واللي نعمل كلر دغري اتس اوكي very epical like انا صرت ابيكس بس نخفف شوي الكلر نزل بالك مع انه رايح على بس مش مشكله يعني ما اوكي
This is, if you look at the 2D here, you find the crossing across the septum. This is a false positive sign. That means that there is no VSD here. So you try again and again, but the crossing of the color does not always mean a VSD. So now we're trying to get the alpha tract, so the aorta. And the aorta usually comes much easier than the pulmonary. Khabir, you worked on this before, صح? Machine. Yeah, mashallah. So now we're trying, Dr. is trying to get the two vessel view, and this is the V sign. And as we said, the longer one is the pulmonary, and the short is the aorta. Now this is a short axis with a hopefully ولا جايب ايش؟ No, it came by itself. But she is not photogenic. Now this is the short axis with the aorta and the pulmonary abutting the short axis, and you see the branching of the pulmonary arteries right and left. Perfect. Perfect. By name, yeah.
I'm sure that حتى اليوم ده ما في مشكله هلا طبعا لازم نرجع نشوفه بعدين بس نو بروبلم.
She's how many weeks? She's 19 weeks, are you? 17 weeks. طيب, so when
We are 20 weeks, 32 weeks. 32 and 22. عنود امورك ممتازه. مش هيك دكتور جورج؟
Yeah.
يلا الحمد لله. يلا next lady.
Now, Dr. George, just a teaching point now. Now, when I did the scan, the imaging were not optimal, and you came over and you did some adjustments to the machine because you've worked it. So what did you do? You put the sector experience and the sector. He did some tricks. I could see that. So no. Let's.
For sure. You know, it depends because it's not automatically.
I just want to say something. You change the settings to the fetal heart. One setting, number one, and number two, you change the position of the probe to the side so you could see the heart in the different. And number three, what you did there is that you started to magnify after getting the 2D. So that was some of the tricks that, as an experienced sonographer or consultant, you did that. It's beautiful.
The next lady, Allah with uterine artery. We have a Doppler scan now. The last lady. We will do. So, سلامتك يا عنود. يلا Allah, the next lady with the abnormal baby. She is 38 weeks with huge encephalocele, occipital encephalocele, and herniations of the cerebellum. We thought it's a quick scan, I think 5 minutes. بس تحكي لها عن البرين دكتور جورج والاوتكم احنا بنشرح لها اياه. Occipital bone defect, a huge occipital with herniations of the brain tissue. 38 weeks. The cesarean sections I think next week. وين الدكتور؟ وين زوجك؟ Next week حكينا الاثنين عمليتها. Yes. بس البرين دكتور. The spine is intact. There's a movement in the lower limb.
And the indication for cesarean?
It's just the indications. They opted for active management. Yes, active management.
Okay, the back is on the right, and as you see here, we can see here the cephalic. You see the cranium, and just even before showing anything else, we have, as you see, we are 38 weeks, and look hard head circumference. Even if I can change a little bit, it's not more than 30 weeks. It means that we have 8 weeks delay. So imagine that we haven't seen the malformation yet. I just want to show you. So if you have this, you go immediately to the femur to be sure that you have no problem with the age, with gestational age. So take the femur, as I explained to you, parallel to your probe, and then up femur length, auto measurement, and it gives you femur 68 to 67. It means about 35 to 36 weeks. So perhaps there is a little bit IFGR, but there is a huge difference between head circumference and femur. It means that we have microcephaly for sure. So when we have microcephaly, we have to search for the reason, and I have the reason I will show you, but we have to see else. Look, the kidney, they have a problem on the kidney. As you see here, adrenal gland, and the kidney, you have dilatation with the pylon and the callus. And you can, the other kidney, up, the other kidney is a little bit difficult. It's here. Up. We have difficult to have the other kidney at this age. this is nice. Okay. The baby is turning. I'm not sure that the other kidney is in place. It's not in place. We have a problem with the other kidney. No, it's okay. It's okay.
Sorry?
The other kidney, it's not well seen.
It's not seen.
No, not seen yet, and I have to go by here. Let's just go. Oh, it should be here. Anyway, there is a problem with this kidney. So there is problem with kidney, and then I will see the heart. So the heart at this gestational age, it's normal that there is a little bit of asymmetry between the two ventricles. Okay, this is normal. يعني 37 or 38. Okay. I don't know the heart, but there is a little. Okay. The right atrium is a little bit bigger than the left. This is the left. We have a little difference between the two. And also, okay. بس لشوف البرين هلا لحظة. The brain, you have a lot of things in the brain. First of all, you have always the ventricle who is far from the probe. You can see it better than the is proximal. So here the ventricle is a little bit dilated, but not. It's like a water flow. Okay, 10 millimeters. It's a little bit, but especially you can see here. You have a large encephalocele, very, very large, and this is what explains the microcephaly. You see all this is the encephalocele. It's more than 7 centimeters, 70, and even the cerebellum is not well found. So this is a huge discrepancy. So you have.
Maybe is in the breech presentations or cephalic.
No, cephalic.
So can we
have one umbilical?
Single umbilical
Yeah,
arm.
single umbilical.
So can we deliver her vaginally because she booked for cesarean section?
This is a very good question. We never ask this kind of question in France because really we never arrived at this stage of pregnancy. لأنه بكون عملنا الأكشن قبل. Like, is there any consanguinity between the two?
First cousin.
So I'm sure that we. Huh? إلى البيبي الكروموسوم مش مشكلة بس
First cousin and her husband
يعني
and doctor.
الجين هو هذا الجين
تولد
هذا الجين.
The couple is the first cousin and he's a doctor. He's sitting here in the.
Okay.
So if you outcome correction this year 15 لا مو على الكيليا الأخ. Okay.
Very small ears. The ears on this you see 20 millimeters 20 millimeters ear. It's about equivalent of 22 weeks, 23 weeks, 24, 25, but not more. You see the ear? شفت
Okay.
So
So Dr. George,
very low ears.
yes. Could you just explain to them the outcome and because it has 2 minutes?
يعني I think that there is hypotelorism, huge hypotelorism because the eye from here to here. So you see, usually we can put an eye between the 2 eyes. There is 14 millimeters between the 2 eyes, and the diameter of the eyes is 17 millimeters. So we have microphthalmia and hypotelorism. And you have a facial dysmorphia, and I think that
وين الدكتور؟ تعال تعال.
Cesarean, okay, بس very bad outcome. I'm not sure it's either in the
اوكي يعني الاوتكم زي ما يمكن تظهر عمليه التوازن حسب السبب اللي عامل المشكله او المشكله زي ما شفنا صحيه فخلص نشوف يوم الاحد او يوم الاثنين على اذا خلص عمليه خلص ان شاء الله خلص ناكل سلامتك سلام نفحصه بنأجلها كمان and for postnatal examinations for whole exome because first cousin يلا مرة the next lady the last lady is from Gaza. طيب أحكي دكتور جورج؟ طيب the last lady is from Gaza with a previous history of abruption placenta. There is no child at all. Now she is 31 weeks with a small baby at the 21st centile, very high uterine artery, very high umbilical artery, VI, with normal ductus venosus. No, now what we need is to do umbilical artery Doppler, ductus venosus and uterine artery.
The back is on the left, so the left of baby is here, so the stomach is on the left, the gallbladder is on the right, it's okay, aorta is on the left, inferior vein cave is on the right, the heart is okay, the apex, and then the Doppler is here, we have okay, up. Okay, so هذا الأمبليكال umbilical IR 0.81. It's a little bit high. We have to see the MCA immediately. Okay, MCA is here.
1.2.
It's better the MCA. MCA 0.82. You see, the resistance in umbilical is a little bit high. Okay. For the moment, there is no indication for delivery, but just to see that you have to control. هذا الدكتوس فينوزس يصير دكتوس اوكي. انا بطلع اكثر شيء الاندكس اوكي. انا باخذ اعطيهم هون البي ال اي حتى الاندكس هون بس بي ال اي 0.43 it's nice. بس بس sure that you have here a huge A wave no problem. يعني مش نازله كثير اوكي. هلا اليوترين artery look I'm trying to do it here. هلا عندها هذا اليوترين اوكي. هلا بطلع البي ال اف هذا اليوترين artery right one okay very okay. You see PI 0.7 will RI 0.4. لا كم فوق الكلاس بعد ما هلا عارفين
جورج
ايه هذا اللفت.
شو فايدة اليوتران ارضي هلا؟
بس هم طلبوا asking لا هم asking for teaching
شو؟ هذا
دكتور
You do uterine this gestational age, or you just showing them?
usually I don't do it. But because he asked me, I say okay. But usually when he gets to it's okay. بس لا الريزيستنس بالامبليكال عالي شوي. اوكي بس بده فولو اب يعني 31 I think. ايه بدك اياه امسك هاي امسك هون امسك. هلا بس بدنا نحط بدنا نعملها امسك بس لفرجيكم كمان انه بنحط الباور دوبلر راديو وبنحط هيدا الشيء نوع جديد يجيب احسن. نحط شو اسمه حاطين الام في فلو ولا ام في فلو. شفتوا الام في فلو يعني عند الجنرال اكري بسموه اس فلو سلو فلو. هلا هون الام في فلو احسن اوكي. لكن هلا بس سؤال شفتوا هون البوليجون اوف ويليز وهون بنشوف هيدا الكاسما اوبتيك كاسما and pituitary tissue optic plasma and pituitary. هيدا الام سي اي اوكي. حلو الكلر ده. شو؟ polygon of Willis. Polygon de Willis polygon. I'm to the circle with polygon because it's a polygon. It's like the pentagon of of Trump, yes. Okay.
دكتور هلا هي
ما عندها ولا child. هي الفكرة هي 31 plus 2 weeks plus 2 days.
Okay.
Now the timing of delivery and the timing for dexamethasone. Once it's positive يعني wait لما يصير negative الدياستوليك flow ونعطي dexamethasone ونولد مع مغنيسيوم ولا twice with
لا انطر الدوبلر ما هلا I wanted to explain because okay I just بدك تشوف الهارت when you want to see the heart okay just when she's doing the heart I want just to explain for me the Doppler ما هي the Doppler I have another way to explain when you deliver. For Doppler when you have a chronic epoxy when the blood coming by the umbilical vein, everything what we call in France we have a new distribution of the blood. So you have less hard oxygen or blood going to the liver and less to the lung, and you have less also for aorta. So this is why, because you have less than the supradiaphragmatic aorta, the index of resistance go up for umbilical artery. And then when you need more oxygen, what's happening in the brain? The MCA will open more and more. Like this, you have less resistance because you have vasodilatation. And the ductus venosus is the image of right atrium. Okay, so if you have a lot of dilatation in the brain, in the MCA, you have a lot of returning blood to the right atrium with the superior vein cave. When the atrium is very big, the ductus cannot give blood inside the right atrium. At this moment, you have to take off the baby. Abnormal ductus. You have to wait.
انا اللي بحكي لانه على 31 previously ابربشوا والبيبي ديد وراحت emergency والانترستنج at the same time هي وامها راحوا على نفس المستشفى وامها ابربشوا وهي ابربشوا هي نفس المريضه.
I think timing
is zonable.
You have to do 34. You have to do 34.
الدكتور هي
33. One week before 33, 33.2.
البيبي is مش quite small يعني بس border line small. نعطي مغنيسيوم
لا شو بدك تعطيه دكساميثازون هذا؟
اوكي
اوكي خلاص we conclude.
يلا طبعا ثانك يو على كل اللايف اللي عملته دكتور جورج وعلى شركه سامسونج طبعا ثانك يو على الجهاز الكويس والحلو طبعا مطنشينا سامسونج خلص ماشي ننسى الموضوع خلص نرجع على الجديد. طيب الامور كويسه الحمد لله وشكرا للمرضى اللي استمعوا لنا
Thank you for staying late. We'll see you tomorrow morning.
at 9 o'clock.
يلا.